Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Addressing the Use of Language and Stigma Towards People with Substance Use Disorders in the Healthcare Setting. And our presenter is Dr. Ramsey, Chief of Medical Services at New York State OASAS. She will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks, Dean. So our learning objectives today are to describe stigma in the healthcare setting towards people who use drugs and describe key provisions of the 21st Century Cures Act and best practices in person-centered, strength-based language, communication, and documentation. So first, a quote and some food for thought. Strong evidence suggests that direct, forceful, aggressive approaches are perhaps the least effective way to help people consider new information and change their perception. Such confrontation increases the very phenomenon it is supposed to overcome, defensiveness, and decreases clients' likelihood of change. And that comes from William R. Miller, PhD. So first, let's discuss stigma in the healthcare setting towards people who use drugs. So let's define stigma initially. So stigma includes attitudes, beliefs, behaviors, and structures at multiple levels. So this can include individuals, groups, organizations, and systems, and can lead to prejudice or discrimination against people with mental health diagnoses and substance use disorders. Stigma perpetuates stereotypes and assigns labels such as dangerous, non-compliant, or incapable of managing treatment. At its worst, it labels persons with substance use disorder, particularly those who are still actively using, as dirty. We would never attribute such a negative attribute to someone with any other diagnosis other than substance use disorder. And it implies that persons are at fault for their diagnoses. It can be internalized by people who are experiencing stigma to make them feel that they are not deserving of being treated with dignity and respect. So this initiates feelings of fear, shame, and isolation, or feeling unwelcome, judged, or unworthy of seeking or receiving services. So ultimately, it limits a person's ability or desire to access services. And ultimately, what that leads to is suboptimal and sometimes traumatic healthcare experiences and health outcomes for persons with substance use disorder. So here's an example of stigma towards a person who uses drugs in the healthcare setting. On the left-hand side is a picture that was hanging in a health clinic. So stop hurting yourself, cook something else for dinner, there is a better way to live. Again, how is that going to make the person who uses drugs feel when they enter the clinic and see such a stigmatizing picture on the wall? So healthcare providers have high feelings of stigma and bad feelings, generally speaking, towards people who use drugs, in part from derogatory or dehumanizing language that is commonplace in the healthcare setting. Studies indicate that the language used corresponds with providing poorer treatment, and stigma at the moment of healthcare seeking discourages people from seeking additional help for their needs. So let's look at how stigma does impact persons with substance use disorder. So substance use disorders are probably more highly stigmatized than any other health conditions, and I'm including mental health diagnoses, HIV, and hepatitis C. Stigmatizing attitudes towards certain behaviors and groups are widely accepted, often culturally endorsed, and enshrined in policies. So think about some of the stigmatizing language that's used in procedures and policies at, for example, health clinics or substance use disorder treatment programs. Substance use disorders are often treated as a moral or a criminal issue rather than a chronic health problem. And healthcare providers may hold negative beliefs about people with substance use disorder. For example, they overuse system resources or are not invested in their health, or they, quote, abuse, unquote, the system. And research indicates that stigma contributes to a host of adverse outcomes for people with substance use disorders, including poor mental and physical health, non-completion of substance use treatment, delayed recovery and reintegration processes, and increased involvement in risky behaviors, for example, needle sharing. And what about stigma towards people who use drugs in general? So stigma, again, as we've established, is a barrier to help-seeking behavior. So again, stigma at that moment of healthcare seeking discourages people from actually seeking the help that they need. It does not discourage substance use, but rather, because it fosters feelings of worthlessness and hopelessness, is often triggering for ongoing use. People internalize, reject, or react to external stigma, and commonly they experience dehumanization. And this results in delayed presentations to healthcare, not disclosing substance use, downplaying pain, and seeking care elsewhere, or perhaps not seeking care at all. So let's look at the interplay between perceptions and stigma. So in non-stigmatizing conditions, there is low perceived fault and low perceived control. An example of this would be breast cancer. However, in stigmatized conditions, there is high perceived fault and high perceived control. So this would apply to how persons with substance use disorder are perceived, even though in order to meet the diagnosis for a substance use disorder, an inherent component of having a substance use disorder is a compulsion to use over which you have no control. So let's look at the impact of stigma. So on the right-hand side, let's talk through these points around how stigma can impact our patients. So first of all, when we have stigma occurring in a healthcare situation, it's ignoring the story of the patient and it's projecting our own agenda onto the patient. It's requiring this, that, the other thing, so X, Y, and Z, because they won't do it otherwise. So in other words, it's not low threshold, but it's creating a high threshold of care in which people are destined to fail because they can't complete all the steps to get from A to Z. And it only talks about the disease and not about what they have control over. So in other words, it puts all focus on one aspect of that individual, their substance use disorder, without looking at other aspects of their lives. And the beliefs in a stigma tree are they're probably lying, they don't have the willpower, and they can't help themselves. And the perceptions around individuals is that they're not trustworthy, they're lazy, and they're sick. So how about if we reframe that as a tree of liberation and look how a non-stigmatizing environment would act out for our patients or play out with our patients? So you can create plans together based on the patient's individualized goals. You can ask clarifying questions to understand their whole story and their needs. Many persons with substance use disorder have significant trauma histories, and so you can allow them space to tell their story and how they ended up on the pathway that they're currently on. And you can share resources and education for their friends to have. The beliefs on this side of the tree are they can do X, Y, or Z. They're telling me the truth, or they're telling me their truth, their story. They care about the community and that they are capable, trustworthy, and caring. And I would add to that resilient. So consider the relationship of stigma and trauma. Realize that most people have experienced trauma. So whether that's a personal or individual trauma or a generational or historical trauma. People with a substance use disorder are more likely to have experienced trauma, including trauma in medical or healthcare settings, and recognize how trauma affects people. Trauma impacts physical health, neurobiology, and cognitive, social, and emotional functioning. And perceived high-risk behaviors can be a way of coping with trauma. So in other words, it's a reaction to experiencing trauma. So consider how past histories of trauma, violence, and layers of disadvantage and stigma can impact our patients, and consider how this may affect the way that a person engages with providers in the healthcare or substance use disorder treatment setting, and commit to not repeating trauma or creating more trauma, or in other words, re-traumatizing our patients. So it's important to understand the role that adverse childhood experiences, or ACEs, have on our patients and the impact that these have on their health. So what are the components of adverse childhood experiences? They include physical, emotional, and sexual abuse experienced in childhood, emotional and physical neglect experienced in childhood, and household dysfunction experienced in childhood. So a parent with mental illness, a parent who is incarcerated, a parent with a substance use disorder, a mother treated violently, and divorce or separation of parents. And these lead to not only actual neurobiological changes in the person who experiences them, but it changes and disrupts neurodevelopment. It leads to impairments socially, emotionally, and cognitively. It may cause them to adopt health risk behaviors, and eventually that can emerge as developing substance use disorder, mental health diagnoses, or other physical diagnoses such as heart disease, social problems that may go along with some of those diagnoses, and actually leads to early death. So understanding trauma and trauma's effects on the body is another component to helping understand our patients and what they experience and how that impacts them. So a traumatic experience actually elicits an immediate physiological response and has long-term effects on the brain. So during stressful situations, the pituitary gland in the brain, which releases neurohormones, releases them in response. So the adrenal glands, which are located above the kidney, they actually release adrenaline and cortisol, so sort of that fight or flight or freeze response. The adrenaline induces a quick fight or flight or freeze response, and the cortisol elicits long-lasting stress responses and shuts down the release of other neurohormones. There are actually also anatomical and physiological changes in the brain. So in one part of the brain called the anterior cingulate cortex, which is involved with rational decision-making, so being able to weigh consequences of our actions, et cetera, it appears smaller in people that have PTSD. And the hippocampus, which is involved in long-term memory formation, also appears smaller in people with PTSD. And the amygdala, which is a part of the brain that processes memory and emotional reactions, is overly responsive in people with PTSD. So how do we define trauma? What is it? So it is exposure to actual or threatened death, serious injury, or violence in one or more of four ways. Either the person directly experiences the event, or the person witnesses in person the event occurring to another person or persons, or learning that such an event happened to a close family member or friend, or experiencing repeated or extreme exposure to aversive details of such events. So for example, first responders or persons who are in the military. So how do we practice trauma-informed care? So there are the 4 R's of trauma-informed care: realizing that widespread impact of trauma, recognizing signs and symptoms of trauma in people, including patients, their families, staff, and clinical team members, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and seeking to actively resist re-traumatization. So what are some of the general principles of trauma-informed care? So utilizing universal trauma precautions. So this is similar to universal precautions we'd expect with respect to infectious diseases. So for example, gloving with anybody when we have physical contact. So in this instance, universal trauma precautions would be assuming that the person in front of you has experienced trauma and therefore be utilizing trauma-informed care. It's being able to adapt your clinical situation to whatever is happening at that moment in time. So for example, if you started to do a physical exam on someone who went into a PTSD response because of sexual abuse they've had in the past, you need to be able to pivot and reorient the visit and to address whatever's happening at that moment in time. It's also recognizing that one trauma is not all trauma. So one person's sexual trauma is not the same as another person's sexual trauma, but realizing that each individual has a story of what happened to them and each trauma is unique. And it's anticipating shame and stigma that your patient may feel and recognizing that and supporting them when they feel those feelings. So what we say and how we say it matters, and bad language perpetuates stigma. So words perpetuate stigma, especially when they imply fault or immorality. So stigmatizing language in medical records not only affects how the patients feel, because patients can access most of their medical records at this point in time, it can also affect the care that they receive for years to come by perpetuating bias among other providers. Another thing that happens, unfortunately, in the electronic medical record is people can cut and paste notes. And so that same bias may literally be cut and paste from note to note to note going on in time. It's important to use person-centered language, so describe the patient as someone with a substance use disorder. Do not use words such as alcoholic or addict or substance abuser, which all have a negative connotation and all make that the entirety of what a person is rather than just an attribute of the person. Use language that reflects an accurate science-based understanding of substance use disorder as a complex medical condition. So use clinically accurate, non-stigmatizing terminology, such as opioid use disorder or tobacco use disorder, and avoid moral judgments, assumptions, or subjective language. So just a reminder on what person-centered care is. So this means that persons, our clients, our consumers, our patients have control over their services, including the amount, the duration, and the scope of services, as well as their choice of providers. So person-centered care is respectful and responsive to cultural, linguistic, and other social and environmental needs of the individual. So person-centered care practices cultural humility. And person and family-centered treatment planning is a collaborative process where our care recipients participate in the development of their treatment goals and the services provided. So in other words, they're not dictated by the service provider. So that treatment planning and care planning is strength-based and not deficit-focused, and focuses on the individual's capacities, preferences, goals. So again, it utilizes the individual's strengths, and those are incorporated into the treatment plan. So effective person-centered care planning strengthens the voice of the individual, builds resiliency and self-efficacy, and fosters recovery and how that looks for that individual. And it's also important to note that while person-centered planning is respectful and responsive to the needs of the individual, it also occurs within the professional responsibilities of providers and care teams. So a few years ago, the New York State Department of Health AIDS Institute put out some recommendations for improving language and establishing stigma-free supportive service delivery environments. So I'm going to go through these key points. So as I've mentioned several times, importance of using person-first language. You also use identity-affirming language, so encourage positive talk in our patients rather than negative talk. Establish a welcoming environment, so create a safe space, and that can be with signage or the way that your environment is set up, et cetera. Make it welcoming, and that could be including artwork or colorful posters, or there are many, many possibilities for how to create a welcoming environment and safe space. It's recognizing the value of staff being representative of the community served, so reflecting your community, It's building staff skills to dialogue with clients or patients about language, and be on the alert for judgmental language. And when you hear that among your coworkers, so for example, the use of clean or dirty to describe either people or toxicologies, then call them out on that and talk to them about why that language is stigmatizing and make suggestions on better language usage. Use quality improvement to dismantle stigma, promote ongoing discussions regarding stigma, and document agency policies, practices, and progress toward eliminating stigma. So this is not a one and done activity. This is something that can take years to change in an agency. It's also important to use person-centered and strength-based language, not only verbally, but with our written documentation as well. So I've given several examples. Instead of using the term addict, you would use person with a substance use disorder. Instead of using the term frequent flyer, you would use a person who utilizes services and supports when necessary. Instead of referring to someone as manipulative, you may call them resourceful. Instead of describing someone as resistant, you could say chooses not to, isn't ready for, not open to. Instead of saying suffering with, say working to recover from, experiencing, living with. So what are some other uses of better language and less stigmatizing language? So again, I've talked about person first language, so I'm gonna skip that, and I'm gonna skip the clean and dirty because I've addressed that. Another common terminology that is used is describing babies as, quote, born addicted, unquote. So it's really important that we not use these inaccurate labels. If, for example, a baby who is exposed to opioids while in utero is born and experiences physiologic opioid withdrawal, that would be described as neonatal opioid withdrawal syndrome, or NOWS. So babies or infants cannot be, quote unquote, addicted. So that involves behaviors, and that is how we define addiction, is by DSM-5 criteria. And as I said, it's a compulsion to use over which a person doesn't have control. Babies don't exhibit those behaviors and therefore cannot, by definition, have an addiction. So it's physiological withdrawal that can be easily treated, sometimes with and often with non-pharmacological means, and sometimes requires medication. But again, this is not something that is a chronic situation. This is a temporary situation that's predictable and easily treated. And then again, the term, unfortunate term of medication-assisted therapy makes it sound like that the therapy is the real part of treatment and the medication is just sort of a tack on. And so we know that that's not true. So it would be better to describe it as exactly what it is. It's medication for opioid use disorder, or MOUD, or medication for alcohol use disorder, or addiction medication, or medication for addiction treatment. So all of those terms are value neutral and precise. So it's better to use that terminology than using the unfortunate terminology of medication-assisted therapy or medication-assisted treatment. So there was a study that came out a few years ago that compared two paragraphs. So it was the exact same situation in each of the paragraphs, but in one paragraph they used deficit-based language, and in the other paragraph they used strength-based language. And they found that actually people responded to the deficit-based language by viewing the person described as less likely to benefit from treatment, more likely to benefit from punishment, and more likely to be blamed for their illness than in the exact same paragraph where the person was described in strength-based language. So words actually do make a difference in how we think about our patients and how we approach them and anticipate their response to treatment. So here is that example that was used. So first, let's go through deficit-based language. So Mr. Williams is a substance abuser and is attending a treatment program through the court. 1 month ago, he was found to have 2 dirty urine toxicology screens, which revealed drug use, and a breathalyzer reading, which revealed alcohol consumption. Mr. Williams has been a substance abuser for the past few years. He now awaits his appointment with the judge to determine his status. So let's pivot and use strength-based language instead of deficits-based language. Mr. Williams has a substance use disorder and is attending a treatment program through the court. 1 month ago, he was found to have 2 positive urine toxicology screens, which revealed drug use, and a breathalyzer reading, which revealed alcohol consumption. Mr. Williams has had a substance use disorder for the past few years. He now awaits his appointment with the judge to determine his status. So again, the strength-based language is not disparaging, and it is morally neutral. So how can we improve our documentation? So first, let's go over some key considerations for documentation. Just write the facts. So documentation should be value neutral and objective. So when documenting subjective information provided by the patient, use direct quotes. And then also include the who, what, when, where, why, and how. Avoid dismissive, emotional, negative, or judgmental language. So terms that, again, have negative connotations, such as hysterical, difficult, disheveled, manipulative, I would certainly add on to that list. Be mindful of your own perceptions and biases. Be mindful of the patient's current name and pronouns to avoid misgendering them. And if you're not sure, ask or use non-gendered language, such as they. Keep it relevant, so don't include unnecessary information. Note a client's appearance, hygiene, or outfit only if it is relevant to their treatment, not just to comment on it. And ask yourself when you're writing your documentation, is this pertinent to the patient's care? If it's not pertinent to the patient's care, it should not be included in your documentation. So what are some examples of objective documentation? Quote, the patient seemed anxious, unquote, is not objective. A better way of describing this would be, quote, the patient expressed fears about the future, was shaking, and said she was having panic attacks, unquote. That is more useful information. It's descriptive of actually what the patient expressed, as well as talking about the appearance of the patient physically as related to the description of what she is experiencing. Instead of, quote, patient seemed depressed, unquote, try instead, the patient said, quote, I've been feeling really down and depressed lately, unquote. Instead of, quote, patient using substances frequently, try, quote, patient reports using 0.5 grams of heroin 4 times per week, unquote. Through new federal legislation, patients can have access to the vast majority of their written chart. Briefly define or simplify medical terms such as short of breath rather than SOB, again, an abbreviation, which might be misinterpreted, or dyspneic, which the patient may not understand. Highlight the patient's strengths and achievements in addition to his or her symptoms. Describe behaviors rather than labeling the patient or making judgments. For example, patient could not recall would be better than saying poor historian. Patient is not doing X rather than saying non-compliant. Patient prefers not to, or patient declines instead of patient refuses. And what are some privacy considerations that should be on your mind? Think about who will have access to this information and if it could pose any potential risk to patients to include certain information. For example, a transgender adolescent who has not yet shared their gender identity with their parents, or a survivor of intimate partner violence who is currently living with the abusive partner. And take the opportunity for shared decision-making with the patient. So, for example, I think this information is very relevant to your health, but I recognize that this could be very sensitive. Is it all right if I include it in your medical record? Or, does anyone else in your household have access to your patient portal? Is there anything that you would be scared or worried about them seeing in your medical record? So better documentation is an opportunity to bridge the gap and build trust with our patients. So you need to always remember that patients likely will see your documentation. It has the potential to improve trust and improve and increase expectations for the quality of care, patient satisfaction, and patient outcomes. Patients with substance use disorder will anticipate and look for stigma. For patients who have had negative or traumatic healthcare experiences in the past, each interaction is an opportunity to rebuild trust, or on the opposite side, to continue to re-traumatize patients. Medical record documentation is often the first impression for new clinicians. So reading stigmatizing language in the medical record is shown to increase bias, reduce empathy, and even change the care that patients receive. By reviewing their health information outside of the healthcare setting, patients are more engaged and more in control of their health and care. So in conclusion, stigma towards people who use drugs in the healthcare setting is unfortunately too commonplace and has consequences with respect to affecting negatively both clinical outcomes and amplifying health inequities. To improve engagement in care and health outcomes with people who use drugs, healthcare providers should be applying harm reduction practices, trauma-informed care, motivational interviewing, and up-to-date substance use disorder treatment practices in a person-centered or individualized manner. So thank you very much for tuning in today. And this last slide is just to reemphasize that recovery is individualized. So this is a process of change through which individuals move to improve their health and their wellness, live a self-directed life, and strive to reach their full potential. So for example, with the hierarchy of needs for persons with substance use disorder, it's going to be hard for them to try to manage their substance use disorder or their health issues, for example, if they don't have a safe and stable place to live and they don't see purpose for their lives or supportive relationships that form a community for them. So it's important that when we're thinking about our patients and trying to help them on their pathway to whatever form recovery takes for them, that we keep these aspects of their lives in mind to help them create more positive outcomes for their lives. So thank you very much. If you have any questions, you can contact me at my email here, and I'll turn it back to Dean.
I want to thank our presenter, Dr. Ramsey, for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.